A quick note before we start, you can find all links and resources discussed in the video description, and please use them to support us. Please also comment, share your opinions, and ask any questions. Thank you and enjoy.
Hey, thank you. Thank you so much for having me on today. Really excited to talk to you guys. I know I sent a message in the chat a while ago, but I'm happy to finally get the chance to, give you guys a hand and see if I can answer some questions and just provide a general outline of what to expect, challenges you can expect to overcome, and then also some advice on choosing your specialty. So I think we can go ahead and get started. My first presentation here. The way we're going to do it, I got a couple of presentations, and then we'll do like a little Q&A section. Okay, nice. All right, so this presentation is called Becoming the Exception, because matching in the US, it's a tough process, and really you have to establish yourself as exceptional in order to actually successfully do it. So I'll start out with a timeline. Residency in the US for a US student, the way that it kind of works is, so they do 4 years of undergrad, followed by 4 years of medical school. And then after that, they apply to a residency, right? After you do your residency, which is a preset length of time, you're fully boarded in the specialty of your choice. So after medical school is when everybody kind of diverges and chooses the specialty that they're going to be working in for the rest of their life, hopefully. Bunch of different options available, pretty much everything you can imagine, and some more, from more common options like psychiatry and internal medicine and emergency medicine to some things that are a little bit more niche, like nuclear medicine or occupational medicine. So things that are necessary for an international person to match as far as a timeline goes. The things that you want to knock off are going to be your step 1, your step 2, some clinical experiences, then getting your ECFMG certification. So when talking about the exception and the what actually needs to happen, the best way I can illustrate this is by match rates. So here we have a chart with specialty on the bottom and then match rate and expressed as a percentage along the left side, with the different bars being US versus non-US IMGs, meaning an international medical graduate who has a US citizenship or not, right? And so you see here, all these numbers are pretty low. And this is not just like a random group of people either. These are people who've taken step 1, paid thousands of dollars, spent years of their life studying for step 1, step 2, traveled to the US, spent even more money and time to go out and do clinical experiences, followed by research. This is like a 4 or 5, maybe even a 6-year process. And then at the end of that, even still, only about half will make it. One thing to take into account too is these data tables don't actually include the number of applicants who get 0 interviews. This is the match rate for people who have 1 or greater interviews, and that number represents like a good amount of people. So to include the actual match rate is usually about 10 to 15% less than what you're seeing here. And as you can see, there are some specialties that are definitely more friendly towards international medical graduates, like pathology here, pediatrics, neurology is a classic. And that's pretty decent. When you adjust it for 0 interviews, you're still hanging around 50%, but that just means that you have to be better than half, right? Hence the exception. Odds are unfortunately stacked against you. So this is a chart showing from program directors in the US, talking about interview habits. So the different colored bars on this bar graph tell you how often they interview certain types of applicants. So for example, 34% of programs almost never interview non-US IMGs, and then 47% seldom. There's only 1 in 5 programs that actually often, frequently interview. When you compare that to like a US graduate, which is the US MD senior, the US DO senior, there's the US medical students in their final year, you see it's jarring, right? Then these two, US MD grad and DO grad, are people that went unmatched, like US students who went unmatched the first time around. Given that the US students will have like a 93 to 98% match rate, We do even worse than the bottom 2 to 3% of US graduates, right? So the odds are definitely stacked against you. So you might be wondering, why would you actually do this? What's the reason? I'm from America. I was born and raised in New Hampshire, so this is my home. So for me, this was like the best option. Maybe even the only option. But other draws include like the culture, the environment, the romance of the American dream. In the U.S., it's a gigantic country. You can have mountains, deserts, seas, forests, all within the same place. If you like traveling, hiking, if you want to see a bunch of different areas, and then just be part of what is essentially like a world superpower, and with the benefits that come with that, that's super nice as well, and a draw. Compensation also plays a role in some people's decision, right? The U.S. is, as far as physician pay, it's one of the highest. Rivals, some say the highest, but the numbers vary by place. Academic versus private practice, specialty versus non-specialty. But no matter how you cut it, the U.S. is going to be one of the best compensated specialties, also with the lowest tax burden when compared to somewhere like Australia or Switzerland, which are also top runners. And yeah, overall standard of living is very high in the U.S. Little things that you don't kind of realize when you're elsewhere. Like, everyone's got the iPhones, and like most, if not all, houses have central air and heating. The infrastructure is quite nice as far as like internet and cell service and all that good stuff. These massive grocery stores with everything you could ever want in them. So then bringing it around to what it takes. So in my opinion, there's 3 pillars of a strong application. And these 3 things are your base. And as long as you have these 3 things, everything else goes on top of it, right? But without these 3, you don't really have a leg to stand on. No matter how many extracurriculars you do, if you don't have a solid foundation, your application is not going to be very strong. So STEP score, the USMLE, which, if you don't know, is a 3-part exam taken by anyone who wants to practice in the US. So, regardless if you are a US medical student, an international graduate, or a already trained specialist in your home country, everyone has to take these exams. And your score on them largely determines, what specialty you're competitive for, which one you can get into. Clinical rotations in the US. During medical school, after medical school, you can spend a month or so at a US hospital, work within the system, get letters of recommendation. This is the way that they know that you're capable of working in the US, right? Like, why would they take a random person who's never set foot in the country before, hoping that they'll integrate well, hoping that they'll work well? It's kind of unlikely. So they like to see this. And then research. This is kind of a box you have to tick off, but it shows that you're involved academically and that you're able to do more than just take tests well, that you're able to multitask, and also that you're dedicated to the pursuit of the furthering of medicine, which is a big deal to a lot of programs. So depending on where you are at now, this is kind of a time-sensitive process, right? The clock is ticking. Unfortunately, all of these things take years to do, between step 1, step 2, clinical experiences, research, and programs tend to filter people based on year of graduation. Most common cutoffs being 3-year, 5-year, and 7-year. So, when they look at applications, they get thousands. A lot of them will just, if you're graduating more than 7 years ago, they're like, no, they're too divorced from clinical medicine or whatever, not going to take them. And then they'll, 5-year, they'll cut off some, and 3-year, they'll cut off some too. So the sooner you apply after graduation, the better. So if you're a first year or a second year in the chat right now, you're going to want to choose your specialty, because pretty much from the beginning, you want to dedicate everything you do towards that specialty. Clinical rotations, research, step score, all have to be dedicated towards that specialty. You're going to have a hard time if you try to pivot at the very last moment into something that's completely unrelated to your specialty that you chose. It's not if you have 3 or 4 papers in orthopedic surgery and you decide to go to neurology, these neurology programs are not going to take you seriously when they see that your CV is full of ortho stuff, right? They're going to think, oh, he's applying as a backup or she's applying as a backup. Third year, fourth year, you're going to want to take STEP. So I think the optimal time to do it is between your third and fourth year, step 1, that is. You want to finish your preclinical stuff, just be starting clinical medicine. You want those things like biochemistry, cytopathology, histology to be fresh, because a lot of the stuff in there is like esoteric, mechanism of action of drugs, mechanism of like biochemical disorders. Everyone loves their Fabry's disease and all that good stuff, right? But you want that to be fresh. DNA transcription is in there too, like biochemistry stuff. And then in your 5th and 6th years, once you've taken STEP, you want to find some clinical experiences, either sub-internships, clinical electives, or observerships. Sub-internships and clinical electives offer better learning experience and are viewed more highly than observerships. These are still okay if you can get them, but your priority should be clinical electives or sub-internships. So extracurriculars, this is like anything that you can do on top of on top of those pillars, right? So like advocacy and student governing bodies, or if you like form some interest club about your specialty of choice, or if you volunteer regularly, it's things that like flesh out your application. If you're musical, if you compete in sports, anything like that. Language, unfortunately, this is a huge part of the application process. If they detect a language barrier, like if the interviewers detect a language barrier, it's gonna be tough for you. There's a lot of writing, there's a lot of talking, and there's a lot of communication that happens in clinical medicine. And if you can't understand and be understood clearly, your chances are very slim. Because you have to think, there are just as many people who want the spot as you, and you want to be the exception. So what would the most exceptional candidate be? They'd be, have no problems with language. They'd have no problems with interviewing. They'd have no problems with their research, anything like that, right? So if your English isn't super strong, definitely be time to get on that, either just by speaking it regularly, or, you know how to learn if you made it this far in medicine. I don't have to give you advice on that, but if your English is not your strong suit, you definitely want to make it as good as it can get in time for interviews, because once you've gotten the spot, the interview spot, you got to prove it to them that you can walk the walk and talk the talk. This is just kind of cherry on top. Interviews are not, they don't play a gigantic role in like counting you in, but a bad interview can definitely get you counted out, if you know what I mean. So you want to make sure that you're capable of that. Then, I was a graduate of VUM in 2022. I wanted to go over some of the ways the school helped me. Oh yeah, look at that. It's not at all. The curriculum at my school did not line up with USMLE at all. So you had to learn 2 things kind of at once, or multiple things at once. We didn't take shelf exams, so there's no real overlap there. They signed some forms when I needed it, but unfortunately, you're on your own. The Polish schools are not necessarily invested in helping you get to anywhere other than Poland. They'll sign forms and make exceptions here and there for you, but overall, you're on your own when it comes to studying, securing electives. Unless you're lucky and your school has like a partnership with an American school, and then maybe it'll help. But overall, it's tough going. COVID, I applied during COVID, so clinical experiences were few and far between. Things have bounced back a little bit now, but I guess this is more relevant back then. And then online interviews are here to stay, which everyone should be very thankful for that. Prior to my year, so I did online interviews, but before my year, you had to travel for every interview to the US, to the actual hospital. So if you're in Poland and you're having to go for like 15 interviews, that's 15 or 10 or, however many you can cram in, international flights within the span of a few months. That's very expensive, and, it'd be difficult to get time off from your classes and from the rotation. So, this is overall a good thing for us. So resources that you have at your disposal are going to include VSAS or VSLO, which is the way that you secure clinical rotations. All of our schools are partnered with VSAS, so you can get in there. You look at what clinical rotations are available. You can apply for them. You get letters of recommendation. It's a whole thing. That's definitely something you want to hop on, just so you get an idea of the timeline too. Even if you're not there yet, you want to get an idea for when these things open and when the applications are due. Then Residency Explorer, the free to residency database, as well as charting outcomes in the match. These are all great resources for not only choosing your specialty, but choosing programs to apply to, or choosing programs to signal now that we have signals. They'll tell you things like average step score of matched applicants, or like the size of the program, some like rough, where it is, how it's reviewed. And then charting outcomes there's a big data report that's released every 2 years that tells you, mean number of research experiences or mean number of interviews by ranked applicants. It's full of all kinds of good data for every specialty. And I highly recommend you take a few hours and just look through it and garner as much info as you can from that. So main takeaways, even though this is a really hard process, if you put your mind to it and you try really hard and you do everything you can and you don't give up, and you just keep on making good decisions, you're going to match. That's all that it takes. Choose your specialty as soon as possible. You don't want to be waffling around. You need to know what you're doing so you can dedicate yourself to it as early as possible. Study hard for STEP. This is not an exam to mess around with. It's going to be way harder than any test you'll take in Poland, with a score that matters way more. Failure on USMLE Step 1 is not a good thing for your application and is going to put you in a severely disadvantaged position. And then once you pass it, you can't retake it. So whatever score you get is the score you're stuck with. And then you're going to want to secure clinical rotations before graduation, because after graduation, a lot of programs will, they won't allow you to do clinical internship. They'll limit you to observerships if you're not currently covered by your medical school's malpractice insurance. So that gets a little bit dicey. You want to do it before you graduate so you can have real clinical electives and still be eligible to do this VSAS thing. Because once you graduate, you're not anymore. Okay, so that's our first presentation. Does anybody have any questions? All right. I'm just going to go through a few before I move on to the next presentation. So step 2, CK270, give high boost for. Yeah. So as I said, there's the three tenets, the 3 pillars of an application are step score, clinical electives, and then research. When program directors go to actually look at applications, they have thousands of them. The program that they use gives them the options with a bunch of checkboxes. So it's include only people who are in the USA, include only people who have 1 letter of recommendation, include people who only have step 1 score above this. And one of the ones they use is greater than 0 research experiences. So if you have 0, you have a good chance of getting filtered out. It doesn't have to be like a clinical trial. It doesn't have to be like a massive retrospective cohort study. It can be a case report, about some cool patient that you saw, and you submit it to a random ass journal in Eastern Europe. That's, with a low impact factor. It's fine. As long as it's something to get you on the board, it's okay. And then shelf exam does not help in the application. Can you do clinical rotations before you graduate? Yes. How can you search for US clinical experiences without VSAS? So that's kind of a difficult one, to be honest. Because that's the main portal that most programs go through. So your options from there are searching for independent clinics. So there are websites that will charge you a fee to match you with a US doctor, and then you'll do a month with them and you'll get a recommendation after that. Those work, I've heard mixed reviews, but I have some friends that did use those US clinical elective programs, and they work. I think they're fine. I wouldn't sweat that too much. Even if the reviews seem bad, I would still try to go for at least one or two of those. You still have to apply, and I think they're solid. I think like there's one, it's like Amio or something like that, that one of my friends used. But that's at year two. If you don't have VSAS, you should use one of those programs. And at the very least, if that doesn't work, residency programs will often have some spot on their website that you can contact them directly. So you go to the website of the residency program, you look for a thing that says like medical students or rotating electives. They'll be like, contact this person for more information. You just send like a really nice email with your CV, and then you're good to go from there. So that's how you're going to ask. Is there a difference between pre-medical school research and research during? No, I wouldn't worry about that. I would just put it on your application. Can you do clerkships in the US first year of medical school? You can, but it's useless. You're much better off choosing a specialty, shadowing doctors in Poland, and getting ready for step one. You can't impress anybody as a first year. If you don't, clinical electives in the US are geared for third and fourth year students. So students at the end of their medical school careers, they're expected to act independently, like as interns or junior doctors. You can't do that as a first year. So it's not going to give you a good letter. It's not going to work well for you. The OET exam, yeah, you have to do it. It's just a pass. Pass is a pass. Clinical experiences in different specialties valuable at all? Definitely. There are some that are kind of universal, like internal medicine. You can apply that letter wherever you want. If you're like radiology, I used an internal medicine letter. And then like family medicine letters are very universal, but like subspecialty letters, like, neurosurgery or orthopedic surgery or ENT, they're not necessarily universal, but more general, broad subjects like internal medicine, family medicine, emergency medicine you can definitely use those. Which year would you recommend to start clinical rotations? Once step one is done, so that's going to be like your, depending on you, fourth, fifth, sixth year. Okay, I'm going to move on to the next presentation. So I'm going to share my screen again. All right, so Eddie, can you see my screen?
Yep.
All right, so I made all this business, all this huff and puff about choosing a specialty in first and second year, but this is not something that's taught in school at all. Sometimes you may get guidance, but a lot of the time what ends up happening is you have one good rotation with a good preceptor in a specialty, and then you're suddenly like, oh shit, I like this. But really it was the teacher more than it was the actual medicine itself, right? I'm aiming with this lecture to provide kind of a standardized, more holistic way of evaluating different medical specialties, so you guys have a better idea of what you want to do. So why I feel like I'm uniquely qualified to give this lecture, right? I had some difficulties choosing my specialty. I came into medicine with some preconceived notions about what I wanted to do and where I wanted to end up. So I spent a lot of time speaking to a lot of doctors at all points of their careers and spending so many hours looking at data, compensation, work hours, averages. I think I've boiled down this kind of approach that works uniquely for me. I hope it works for you guys too. But, we'll see what we can do. If I can help at least one person, I think I will have done a good job. So the first step in picking the career that you pick for the rest of your life, right? Because medicine's kind of crazy, right? In some other careers, once you're done with your degree, you can switch kind of however you like, right? If you do business, maybe you want to work in like advertising, maybe you want to work a more corporate job, like you can switch it up. You can change companies. Once you finish your specialty training in medicine, you're locked in. Sure, you can change the modality of your practice, maybe hospital versus clinic, but for all intents and purposes, you need to kind of know what you want before you go in. So questions that are important to ask yourself, like what's important to you and how do you know what's important to you, or what do you want and how do you figure out what you want? These are kind of hard questions without easy answers. Certainty is often insanity. If you don't realize that there's some gray area with a lot of these questions, a lot of these answers, it probably means you have the wrong answer there. You can't always be 100% sure of the specialty that you want, is what I'm trying to say. But one of the ways that you can help yourself is to kind of watch yourself and try to observe yourself. Now, this comes from some kind of Eastern Asian teachings and practices, but you want to try to figure out how you feel in certain situations, right? So look at some of the classes that you've had. For example, patho. Were you engaged when you were in patho class, or were you on your phone? Were you distracted? Like, were you excited? Were you excited to get there, or did you not want to show up and couldn't wait for it to end? If the teacher was late, were you excited about that, or did you rejoice at the idea of a day off? So take that same train of thought and apply it to as many different parts of medicine as you can, right? When a patient comes in, do you like if they're old, or do you like if they're young? Do you like dealing with like the most sick patients, the most healthy patients? Do you like seeing a patient that you've seen 5 times already, or would you rather see one person one time and be done with it? Do you like seeing patients at all, or do you like talking with other doctors? One thing you can do as well is talk to your friends, because we are oftentimes unfair judges of our own feelings, our own motivations. We have our own biases that we bring into it. But by expanding and asking your friends, talking to people around you, you can, even if they have their own judgments and biases, the mean opinion that you get from yourself and those around you is probably going to be pretty dead on, right? Like, if you take, even if a bunch of different people are biased different ways, if everyone's telling you the same thing, it's probably true, right? Ask them, when I talk about cardiology to you, how do I come across? Do I seem genuinely excited about it? Like, do you see my eyes light up? After I interviewed at this program, like, I seem excited. Was I happy for the rest of the day? Like, what did you think? How did you think I felt? Right. And then parents, they can be helpful, but a lot of times they're hit or miss, right? Everyone here has, I'm sure, had to deal with overbearing parents that, I've always wanted you to be a cardiologist, or like they were a neurologist, so you're going to be a neurologist. They bring their own biases to the table. Sometimes, if they're really open and accepting and genuine, they can help a lot, but a lot of the times they bring a lot of their own baggage to the table when it comes to these things. I want to talk a little bit about what I call clout chasing. This is mostly speaking about prestige, right? So certain specialties are considered to be more prestigious than others, right? Like cardiology or neurosurgery. What would they say? It's not brain surgery, right? That's a common saying. So there's a good amount of clout associated with that, right? If you pick something with the prestige in mind, it kind of reflects an internal need for external validation. What I mean by that is, your own feelings of self-worth and belonging don't come from within yourself, but they come from how people feel about you, right? If you are reliant on external validation, it's really hard to make decisions about your own future because your choices aren't going to reflect the things that you want. They are going to reflect instead what you perceive other people want you to do, or what society finds valuable, which is often, it's often flawed in itself because it's your own perspective of that, right? This is going to lead to you being unfulfilled because you're not doing things for yourself. You're like acting on the pseudo wishes of some people and what you think that they want, when in reality, I'm sure they don't really want, they don't care, If you feel yourself feeling this way, it's kind of a big pit to dig yourself out of, but mindfulness exercises, confidence exercises practiced over time will provide some benefit. And really just being aware of when you're acting this way, asking yourself those hard questions we talked about at the beginning, and, making decisions that reflect internal validation versus external. Now, I'm not saying that, specialties like cardiology and neurosurgery are only chosen because of the prestige. Because they're not, they're people who genuinely love these things. But you just have to, those specialties are especially vulnerable because of the high compensation and the status associated with them, right? So what I like to call next is this like spectrum test. So many factors in medicine that make specialties different can be expressed on a spectrum, 1 to 10, right? So use your notes on your phone if you want to do that right now to talk about where you stand on the following spectrums, right? So I think these are pretty all-encompassing, right? So patient contact. Would you rather have a small role in patient's care or a large role in a few? Independence versus interdependence. So interdependence meaning you're working as part of a medical team. So for example, anesthesiologist is quite interdependent because they work with the surgeon almost 100% of the time. Whereas a more independent specialty would be like a cardiologist because they kind of work by themselves in their own realm of practice. Young patients, older patients, recognition, procedures, clinical medicine, training. Healthy patients or sick patients is an important distinction to make. And then work-life balance, of course, this is something that's getting more and more important to people as time goes on, and something to definitely think about because you could end up making a decision at age 24 or however old you are when you finish medical school that impacts the rest of your life and what you're capable of doing. Your family, if you're capable of taking lots of family vacations, or if you're on call every weekend, right? And then risk aversion should be quantified on a scale of 1 to 10 as well, because as an IMG, specialty you choose can be risky, right? If you are dead set on what's the lowest here? It would be neurosurgery for US IMGs. That's tough. That means no matter what you do, you're going to be taking a good risk, even if you're extremely dedicated and you work super hard. It's still going to be risky. Versus emergency medicine with an 80% match rate, it's less risky, right? So diagnostic radiology is my specialty, and I tried to map it on this kind of spectrum we talked about earlier. So I made this this nice little chart here that talks about work-life balance, outcomes, recognition, independence, interdependence, patient contact. And so I tried to take my numbers from this page and see which specialty matches those the best, right? And I'll tell you the answer for every single specialty on this list. You're going to have to do that research and figure it out kind of yourself, or you can ask clinicians in the Warsaw hospitals, kinds of same questions, and see where they lie on the spectrum as well. So different ways to do your own research, going to be like YouTube vlogs, questions with a blank. This is a really nice series, like 50-minute interviews with types of medical specialties. You can join Reddit, subreddits, Discord. Student Doctor Network's pretty good. Shadowing doctors here in Poland is great, and something that I don't see students do nearly enough. Any clinician that you're working with at any point in your studies, 9 times out of 10, if you come to them and say, hey, can I spend some more time with you? I'm really interested in your specialty. They're going to say, yeah, I'm so excited that an English division student is actually invested in their education. Let's do it, So that's always great. Already went through this. And then, so best fit, this is I think this is kind of a problem that a lot of people come into specialty choice with, which is like a best fit or one-itis or whatever you want to call it. And it's the idea that only one specialty is right for me, and if I don't end up in the one specialty that's perfect for me, it's gonna end badly, or I'm gonna hate my life or whatever, right? But not only do I believe most people have multiple specialties that they can live and work completely happily and fulfilled in, but every specialty, or most specialties rather, have a lot of flexibility, right? So in radiology, for example, you do traditional diagnostic radiology where you're sitting in the reading room, occasionally doing procedures, not really seeing patients in person, just more reading scans, talking with other doctors, having a good work-life balance. But then there's also breast radiology, where you run a clinic. You see patients every single day. You talk to them about their scans. You perform biopsies there. And you, again, do have a really robust work-life balance. Or interventional radiology, which is a subspecialty of radiology, where you are a surgeon. You are in the hospital 5 to 7 days a week, depending on how busy you're working. Doing minimally invasive procedures, pinching off bleeds inside the brain, grabbing clots, like doing all sorts of crazy surgery stuff. Scrubbed in the OR with anesthesia, with clinic as well, seeing lots of patients, and then with a less robust work-life balance. Another example, emergency medicine. Traditional EM is shift-based work in the hospital, but look at all these other options. These are all fellowships you can do after emergency medicine, from tactical medicine to wilderness medicine. You can work in healthcare administration, sports medicine, primary care. There's a lot of flexibility, so I don't want any of you to think that there's only one thing that works for you. But regardless, you have to make a choice. So even if you're not 100% sure that you want to do emergency medicine, you need to make the choice and you need to stick with it, because that's how you're going to get your clinical rotations. That's how you're going to build your research, and that's how you're going to focus your application, right? So I figure we could end this off with some step 1 questions. Everyone loves this kind of stuff. Just to give you an idea of what you're in for if you haven't taken step yet. So we got a 44-year-old woman coming in, 10-month history of wide red streaks in the lower trunk, weight gain in the face and abdomen, increased appetite, arms and legs become thinner. So this is a classic picture of Cushing's, right? I don't know where you guys are in your studies, but if you compare these types of questions, the questions you get at your medical schools, you'll see it's completely different. And then the way that they have their distractors set up is pretty insane too, right? You look, these are all pairs. The second of these pairs, hyperkalemia and numerous bruises, hypertension and muscle weakness, right? These are all features of Cushing's. The second options are all features. There's lots of correct answers here, but the first is where it's wrong, right? So you have to pick the correct pair. This is considered an easy question, right? This is the diagnosis is given to you, handed to you on a plate, with this Cushing's, and then you have to pick which lab or physical clinical features you see. The answer is B, right? Hypertension. They get hypokalemia, they get hyperemia, they get hyperglycemia, and jaundice is not involved. Another one, right? This is a microbiology question, so I don't want to read this whole thing, but the idea is 10-month-old boy, moist, non-productive cough, rapid breathing, nasal flaring, rhinorrhea, intercostal retractions with wheezes, bronchi. This is RSV, and then you have to pick the correct, we'll say the, what were they called? The virulence factor associated with RSV, which is mediation of cell entry via fusion protein. So there's a lot of, these questions are not, they're not easy. Just to give you an idea of what kind of stuff you can expect to see and the degree that you have to study for these kinds of things. So those are my 2 presentations. I'm going to take a look at some questions. Anyone who has any more questions, feel free to ask them. If we don't get any more, I'll run through a few that you guys asked on the Google Doc, and then I think we can wrap it up. All right. What type of research did you get involved in for radiology? So I entered a mentorship program at VUM, and I did some research in interventional cardiology, which has enough crossover with interventional radiology to call it have it all work together. A lot of stuff with percutaneous coronary interventions. So that was super solid for me. And that was my big research that was my big research that I did there. I worked with a doctor in Poland, and she said that she'd be more than happy to include me on the project as long as I was willing to write it and donate my English skills. So that was kind of all I had to do, which is nice. It was super nice of her. Step 1 is now pass-fail. Do you think this is better for IMGs? No, this is significantly worse for IMGs. Step 1 and step 2 are some of the ways that we prove that we are just as good as US medical students by showing that we can take the same tests and blow them out of the water, do even better than our US counterparts. But with step 1 being no longer scored, a pass is a pass, and everyone gets a pass. So that doesn't help us at all. We only have one chance to prove objectively, numerically, that we're just as good or better than our U.S. counterparts when it comes to applications. Unfortunately, there was one that I saw, best research program. Yeah, I mean, You know, there's no, I mean, sure, there's like huge US hospitals that do like a ton of research, like in different special. I mean, it depends based on specialty, but I don't think there's a single best. You just want to get in on something. Depending on the specialty you want to do, of course, you know, in emergency medicine, maybe you don't have to do a ton of papers, but if you want to work in like academic internal medicine, you got to do a bunch of stuff, you know, between case reports or maybe, you know, actual studies. Do we have to work an extra year after the 6 years in Poland before going to the US? No, you don't. You do not have to finish your stage to be licensed in the US. I applied during my at the beginning of my 6th year. So as soon as I graduated, boom, I actually graduated early. I went straight to my intern year in the US. So you do not have to complete the extra year in between. How to apply for clinical rotations as a non-US med student. So you can use VSAS or VSLO, or you can look for clinical rotations on program websites and email them directly. How many programs should you apply to in order to match? There are folks that apply to 100 and don't match. That's true. You should apply to every program as far as application strategy goes. There is no strategy. There, you apply everywhere. Unfortunately, US and non-US IMGs, the yield, we'll say the percent yield of applications to invites is usually on the order of 0.0%, like 5%, usually less than 1%. So if you want to get the magic number of like 10 to 12 interviews, you have to apply to 200 plus programs. Is what it is. Signals have made that a little bit harder. You have to signal appropriately, signal to programs that take a lot of IMGs, but really you should apply to every, like, money should not be an object, unfortunately. You can take a loan if you need to. Like it's, you know, I did something similar to that because, you know, extra money spent on applications, if you match, will be made back later. And the more years you wait and the more years you go unmatched, the harder it's going to be. You have to, like, I applied to 400 programs in order to successfully match. It was 120 something internal medicine intern year program, so first year program, 120, 140 radiology programs, and then I backup applied to emergency medicine, which is like another 150, and then like some more intern year programs, transitional years, surgery, because in radiology you have to secure an intern year separately from your 4-year radiology practice. So I kind of had to do double, unfortunately. If we do our specialty, do we have to study extra years in the same field? Yes. So you have to restart. You have to start over again if you do your specialty in another country and then go to the US. The only specialty that has an exception is radiology. If you complete your specialty training in another country and come to the US, if you complete 4 fellowships in the US, accredited fellowships in the US, so 1 year, very high level diagnostic radiology years of training, you're eligible to take their board exam. So you can do that. How many weeks of clinical rotations would you consider enough? You want to do at least 4 weeks. One rotation is 4 weeks long. You want to do at least one. You want to do at least one, and the optimum would be 2 to 3, so a total of 8 to 12 weeks. Did you go straight into residency after med school? Yes. Do I need to pass the LEC, even if I don't want to practice in Poland? No. You only get 7 signals for IM. Yeah, unfortunately, that is true. How many interviews did you have? I had a total of 18 interviews. I had 8 for diagnostic radiology. I had 8 for prelim year, and I had 2 for emergency medicine. Did you start applying for residency during 6th year? Answered that one. Is there a way to be licensed as a GP in the US without specialization? No, there's not. You need to complete an intern year you complete an intern year and then at least 2 years of training in one contiguous specialty. Would you suggest studying for STEP during 1st and 2nd year? Yeah, maybe. You want to have completed all those those preclinical kind of classes, so you have an idea of what's going on. But yeah, second year is fine. Second year is early enough. You just want to be able to take it well enough that you're not going to fail it, because step one's pass fail, right? Say third to fourth year for step one completion. Do you mean we should take it in the summer of third year leading to fourth? That's what I did. Third year leading to fourth year, and that worked. What do you mean when you say intern year? So the first year after medical school graduation, where you're practicing as a doctor in the US, is called an intern year or a preliminary year. It's just another word for saying, like, it's like a stażista in Poland. Like, it's like your first year. Most programs, or like most specialties, don't make a delineation between an intern year and the rest of your studies, but there are some specialties that require you to complete a separate extra year in like clinical medicine. So radiology, anesthesia, dermatology, physical medicine, rehabilitation, a couple others. They say that you have to complete a year of medicine to have a good base before you can start learning this new thing, right? So radiology says, you need to have a good base in clinical medicine before you start radiology, so you know what the heck is going on. I don't know anything about dentistry students, unfortunately. What research do you recommend? Review articles, case studies, original research. They're all okay. They're all totally okay. Do whatever you can. Can you do rotations in different specialties? Yeah, you can. Yeah, I think I answered this a little bit earlier, but internal medicine and emergency medicine and family medicine letters can go anywhere. They can work for any specialty. No idea about the 7th year for the UK. How do you write a stellar personal statement, and how important are they? They're pretty important. Yeah, they're like more extracurricular stuff versus like, pillar kind of stuff, but they are pretty important. And writing a stellar personal statement, I can't really go into that here. It's more just like, you just have to look at a lot of examples and have a concise beginning, middle, and end. Have like an idea that you want to convey. Like, try to focus your whole application around one thing: why you're a good applicant, why you like the specialty you like, and why you want to go to the US. Those are all, it's very personal. There's not a lot of things, not a lot of general advice that I can give. Would you have to match again after the intern year? No, you apply for your intern and your advanced position at the same time. So when I applied in 2022, I matched for a 2022 to 2023 position, and at the same time, a 2023 to 2027 position. I've seen some preliminary residency program that is for 1 year. So those are intern year programs. Those are separate programs where you do 1 year expecting to go on to an advanced program after that. If you complete that on its own, it doesn't really do anything for you. Like, you don't get like a full medical license. You can't practice on your own. I would not recommend just matching to a preliminary medicine year. Like, you can do that if you want, and then you can try to convince them to take you on for a full 3-year internal medicine, but you have to reapply, and there's a chance that it might not work. Furthermore, without getting too deep into the weeds, so in the US, Medicare, which is our like government healthcare thing, provides money to train residents, right? They pay for our salary. Every person who enters residency in the US gets a certain number of years of funding, right? And that depends on what specialty you do. Radiology, 5 years. You get 5 years of funding. Internal medicine, 3 years. You get 3 years of funding. If you match an internal medicine prelim year, your clock starts for 3 years, right? So say you match internal medicine prelim. That's 1 year down, and you still need to do a 3-year internal medicine residency, but you only have 2 years left. Say you try to match again and you don't match. That's another year gone, because it doesn't stop. The clock doesn't stop if you're not in a residency program. So it's not advisable overall. How many articles is enough to be considered in matching? So that you can look at the charting outcomes in the match document. I'm gonna put its name here, or I'm just gonna link it actually. This has all the information you want about number of research papers, number of interviews, average average step scores, all that good stuff, It is this document right here, and this is broken down by specialty, so you want this. Would it be possible to switch from diagnostic to interventional? Yes. After you finish diagnostic radiology residency, you can do a fellowship in interventional. It's 2 years, 2 more years. Very interested in applying diagnostic radiology. Do you have any specific advice regarding the specialty? So specific to diagnostic radiology would be away rotations. So clinical rotations in diagnostic radiology are not helpful. You can do them in other specialties like internal medicine, cardiology, pediatrics, all this kind of stuff. But honestly, there is nothing to be gained by sitting in a room watching a resident read studies for 4 weeks in a row. There's no, it's not useful. You can do it, sure, but it doesn't often help your chances of matching. So, it's not, you should try to get one if you can, but it's not the end of the world if you don't have one in diagnostic radiology. LOR, letter of recommendation from US doctors versus LOR from Poland. Unfortunately, most programs don't care about Polish doctors' letters of recommendations. It would be, those are good if you want to match in Poland, but they don't matter much for matching in the US. You can still use them, but LORs from US faculty are much better. Does being Canadian or UK IMG do anything towards the stats, or are all non-US IMGs seen differently? Yeah, no, it doesn't really change anything. The only type of IMG that is negatively, has a negative, or a different bias, are we call it Caribbean IMGs. So that's US medical school applicants who went to other countries, who finished their pre-med and they do 4-year medical school in the Caribbean. A lot of times they're viewed as second tier applicants, and are generally not accepted at most programs, but there are a few dedicated programs that take mostly Caribbean IMGs. So that's something to think about. If you look in those data tables, you can also see that it seems that there's a large difference in the match rates between US and non-US IMGs. In my opinion, a large amount of that difference can be accounted for by programs that are dedicated to taking Caribbean IMGs, which gives the US IMGs, or this subset of US IMGs, the Caribbeans, it brings their match rate up, right? So a lot of those Caribbean programs have 100% match rate, but only to a few programs in a certain part of the country in a few specialties. So it brings the match rate artificially up. Whereas being a US IMG from who did something like me, where you just go straight after high school to Poland, is still viewed almost the same as being a non-US IMG. And then there's visa issues, but most programs who are willing to take US IMGs will sponsor visas for non-US IMGs. Do we apply separately to medicine to get to radiology? Yes. When you're further along in the ERAS, in the process of matching, it'll make more sense when you're there. If once you've completed steps and have your ERAS token and all that kind of stuff, all the information you need will be in there. So you apply separately. What kind of visa? I think programs sponsor J1s and H1Bs. Does the UK prelim year help anyhow for the US? No, not really. Do they count only first author publications for research? Nope. I put my second author or third author presentation or second author paper in there, and it's totally fine. Yeah, as long as you're most people, if you're on anything, just count it. It's kind of loosey-goosey like that. So a couple questions that you guys have sent earlier in the Google Doc that I can answer are specialties that are IMG friendly. That's internal medicine, psychiatry, neurology, and family medicine are probably, and emergency medicine are the most IMG friendly. And then is it necessary to publish and do research during medical school to match into internal medicine? Yes. I mean, it's not impossible, but it's the very, very desirable. And it's not gonna help your chances, right? Compared to how hard it is to do research, which is, a case report is not something that's necessarily very difficult to do. There's in this charting outcomes document too, you can see things like, mean number of research experiences that are, how many research programs does the average matched applicant have? Like things like that, right? Those will really help you. Then you get a good idea, right? Like, in general surgery, for example, you're more likely to have matched the more research projects you have. This kind of stuff, like among people in general surgery, among people who had 0 research publications, 4 matched and 16 did not match, right? So that's, lets you break it up like that. All right. Anybody else have any more questions? I think if not, we can get ready to wrap it up. I'll give you guys a few minutes to put in any last minute questions. While I look and see if there's anything else here that I haven't covered already. Oh, extracurriculars that helped with my personal application. That would be so I was involved in like our student government. I was president of it in my final year, which I think helped a lot. I was, as far as class rank goes, I was pretty high up there, which helped a lot, I think. And then as far as, and I did a bunch of other stuff. Like I was in like some orchestras and some jazz bands, which I think just kind of like made me more of a holistic candidate. I think they like that. How do you, or are you involved with any telemedicine? No. How do you do well on interviews? This could be its own lecture, honestly, but a couple of things you want are to, you want to be memorable. That's the biggest thing. So you want to kind of have your answers ready beforehand, expect what kind of questions they're going to ask, be ready to talk about yourself. Don't be like, all this kind of stuff. You want to know, why you're there, have clear and concise answers for why you want to go to the US, why you like the specialty, what you think, be knowledgeable about the specialty, like what kind of challenges you think the specialty faces and what kind of things you want to work on. That's some of the good ways that you can do it. They ask what are called like behavioral questions. It's spelled like this. You can Google how to answer those because it's its own thing. You kind of have, it'll be like a 10 to 15 minute read on how to answer those well. It's like, standard interview, like what's your biggest weakness, all this kind of stuff. Why does vascular surgery have such a high match rate? Let's see. Let's look at it. Well, the sample size is tiny. In 2022, there were 6 non-US IMGs that matched and 11 that went unmatched. So it's a very small number. It's probably just inter-year variation because it's generally pretty difficult. You see in there the average matched vascular surgery applicant had 9 research items on there, and then like step 1 and step 2 scores that are like 1 to 1.5 standard deviations above the average. So it's, remains super competitive. Oh, wow. Mean number of abstracts, presentations, and publications for a matched IMG in vascular surgery was 26. So 26 abstracts, presentations, and publications. So pretty, they definitely had to work hard for that one. Step 1 and step 2 studying, I'm kind of far away from that now. It's been 4 years since I took step 1. But I used Anki, I used Zanki a lot, as well as Boards and Beyond, and then UWorld. UWorld is the best. How did you get into the mentorship program that helped you get into research? My dean in 4th year started an English division mentorship program, and I just was very persistent about getting it. Just, hey, who's available? What can I do? Like, other than that, you just, if your school doesn't have that, I would just try really hard, pick your specialty, go to the department after class, say, hey, I'm English division student. I would love to help. What can I do? Like, can I get in on anything? And just be really, be genuine, be honest, and be persistent. And that's how you'll be able to break into the departments. Do you have any knowledge of doctors going to a different country, post-grad, then matching while in the UK? Yeah, so the cutoffs do apply while you're working as a doctor in another country. It's still just like year of graduation. They have year of graduation is in your application, and they just cut it off. It's not going to hurt your application to be working in another country, but it's not necessarily going to be helping you very much. I know of a few people that did their F1 year while they were applying. I have a friend who's doing that right now, actually, and it's something you can do. It works. And you can use letters of recommendation. You can talk about what you're doing, but you also want to be able to explain during the interviews and in your personal statement why you want to come to the US, even though you're already starting down the UK certification pathway. Because they're going to ask you why America, don't you want to all this kind of stuff. But yeah, hopefully I answered all of your questions, guys. I think that just about does it for me. In my intern year, the most hours I worked in a week was about 100-ish, 107 or something, and the highest number of days that I worked in a row was 28 or 32. So intern year is tough and you work a ton, but radiology, the lifestyle is quite good for the actual residency itself. And as an attending when you're fully working as well. Different specialty like general surgery, you can expect to be 80 hours every single week. And most of it is mostly more than 80 hours, but you just report 80 hours so nobody gets in trouble. It's one of those things. Can you explain what made you go for diagnostic radiology in the end? Yeah, I just love it. It's a cool specialty. I like being able to be involved in literally hundreds of patients' care every single day. Instead of having one patient, I have 100 patients, which is it's so cool. It doesn't have a lot of bullshit. A lot of radiology is just working on patient cases, understanding what's going on, and giving answers. In a lot of other specialties, you do a little bit of clinical medicine, you do a little bit of thinking, but then you have to be okay, well, the patient can't go home, so I need to find them a ride home, or the social worker, needs to assign this patient's medications to get home. A lot of it is social work and kind of just annoying clerical tasks that get in your way. Whereas in radiology, it's when you're there, you're working, and when you're not working, you go home. It feels I'm kind of a nerd. I really like the technology behind it too, and I really enjoy the specialty. I like the procedures as well. I like being able to just go into a patient's room. Maybe they're really uncomfortable because they have a lot of fluid in their lungs. You go in, it's all set up for you. Put in the tube, make them feel better, and then get out of there, not having to deal with anything afterwards. It's really nice. As I can see, you're doing this program. Do you have any more resources made by you or that you recommend? For the USMLE, just Zanki, Boards and Beyond, First Aid, Pathoma, Sketchy, and then UWorld is the best. Are you not afraid of AI displacing DR? No, not at all. If you talk to any radiologists, you'll see that you'll get that same answer. And it's only people who are not involved in radiology that think that AI can do the job that we do. Not to disparage your comment at all, but I feel like it's kind of misunderstood what the diagnostic radiologist does from the outside. And, it seems like it could just be well, the lung is dark over here, so that means it's this. But then whereas really we're kind of synthesizing the whole picture, old studies, the patient's clinical status, the information garnered from the clinicians, and the same thing, the same exact finding could mean like 10 different things depending on how old the patient is, where the patient came from, what's going on, what their labs look like, what the doctors tell us over the phone. It's honestly not a threat, at least not for the next 30, 40, 50 years. I like to think that if we're ever at the point where radiology can be replaced by AI, everyone else is as well. Especially things like ultrasound or procedural based diagnostic radiology. It's like, okay, an AI tool can detect a brain bleed, but a 6-year-old could also point at the white spot on a CT scan. It's like the things that it can do right now are not necessarily helpful or time saving. My hope for AI in radiology is that it's going to streamline our workflow a little bit more, be able to pull up old studies quickly, be able to prioritize patients in our list depending on things that it thinks it sees. But as far as replacing, it's got a long ways to go. Do you think AI would affect neurology? No, AI is not coming for clinical medicine for a long time. There are a lot of other things that are going to get displaced by AI before medicine. Problem is liability. The robot cannot be sued, and the doctor can definitely be sued. So that's one of the big things that's coming for us. I mean, think about it. Airline pilots have been using autopilot to get from place to place for years now. Like since the 90s, they've had very advanced autopilots, to the point where they're in the sky. They don't have to do very much beyond landing and flying the plane. But yet still we don't trust the autopilot to do that. We still have that. And I don't think it's going anywhere. What about pathology? Also, yeah, I honestly, I wouldn't be worried about AI in general in medicine. It's one of those things, it can maybe help in the future, but there are so many tenets of pathology. There's so many things just beyond looking at the slide that are not possible to be taken over by AI, especially like gross pathology and forensics. Like, no way. You can't have what are you going to do? Take a bunch of little pictures versus and then upload them for the AI to look at. What's the financial impact of replacing pilots versus replacing doctors? Not super sure what you mean by that. Like how much cost savings would happen if you replace pilots versus doctors? You'd have to look at the data as far as like how many pilots are employed, average pilot salary being like relatively close to your average doctor's salary. It's probably pretty darn similar, yeah. Yeah, the liability is a major there is a financial incentive to seek out alternative ways of fulfilling a healthcare need in the US. But is AI robust enough to capitalization for a doctor AI is higher. Yeah, are the tools robust enough to the point where they can take over and also be able to shoulder the liability? I don't think so. And by the time it happens, it's going to be everyone else gone too, unfortunately. Market cap for doctor salaries being replaced by AI is pretty high, but you could you can make that argument for a lot of other low level types of positions as well, like a lot of office work, a lot of data entry. Is all that could all be taken over, but hasn't happened yet. And I think those things will happen first before things that take over or things that directly impact people's lives on a day-to-day basis. Is U.S. clinical experience mandatory for applying to the States? Yes, we'll call it mandatory. Not 100% mandatory, but if you want to have the best chance that you can, that's it. Why is it easier to get into internal medicine than general surgery? Is it general tendency for surgical specialties? Yeah, pretty much. Surgical subspecialties, they take international people, just not at the same rate. It's really about desirability a lot of the time. Internal medicine. So it's really about desirability. Whatever US students don't want is what we're going to get stuck with. So more people want to do surgery than want to do internal medicine. So we end up with the things that people don't want to do. and the positions that U.S. doctors don't want to take, which is why you see a lot of IMGs at programs in like the Bronx and Brooklyn and all that. Places where people wouldn't want to be. Detroit. But everything's temporary. 3-year internal medicine residency, and then you get to do whatever you want. All right, guys. I think that just about wraps it up. I think we're ready to do it. I really thank you guys all for coming down and asking all these good questions. Anyone who has any more questions for me that are more like either not applicable to the whole group, or maybe you just want like a more personalized answer, I have a Instagram that you can send me a DM on. It's this here, and I'm sure a lot of you guys see me on the in the little group chat there. You can send me a message on WhatsApp, and then there is a feedback form. So if you guys would go ahead and fill that out, that would be awesome. But I think that just about does it. Thank you guys so much.
Please tell us what you liked or disliked about the video, and ask any questions in the comments. If this video is useful, please give it a like. All links discussed in the video can be found in the description, and please use those links and subscribe to the channel to support us so we can keep producing content. Thank you, and maybe watch another video.